Welcome, everyone. Thanks for being here. We're talking financial toxicity in patients. My name is Erin Peterson. I am the Senior Director of Mission and Partnerships for the Colon Cancer Coalition, based here in the Twin Cities. Before we get started, before I introduce the speakers, I had a quick question. Are there patients and survivors in the room and caregivers? Excellent. And are there providers, researchers? What else do we have in the room? Providers in the room? Administrators? Nurses? Research? What else is in the room? Advocacy groups? Awesome. Excellent. Industry? Thank you. Thank you all for being here. I'll do some quick introductions and we'll get started. We have two speakers today. Mike Karasic is the Vice President of Oncology Operations for Allina Health, a large health system located in Minnesota and Wisconsin. As the executive for Allina Health Center Institute, Mike is responsible for the operations and strategy for the Comprehensive Cancer Program. Mike has over 2 decades of oncology leadership experience for both large health systems and physician groups, including prior executive roles at Advocate Aurora and Sutter Health. Mike holds a doctorate degree from Stanford University in International Health Policy, master's degree from Northwestern University Kellogg School of Management. Mike has presented and published articles on oncology trends in management, including value and population health initiatives. Also is Lindy Yanukovych. She is the founder and executive director for Cancer Legal Care, a nonprofit organization providing free legal care to Minnesotans affected by cancer who also face any number of legal issues surrounding employment, insurance coverage, disability, housing, and estate planning as a result of their diagnosis and treatment. Compelled to bring cancer legal care to life after witnessing firsthand the many legal questions and difficulties her loved ones faced after being diagnosed with cancer, Lindy counts her work with Cancer Legal Care as the most profound and gratifying of her legal career. So we'll start with Mike and go to Lindy, and then we'll have some Q&A at the end. So if you have any questions, hold those, and we'll come around with the mic after the presentations. Mike?
Good morning. Thank you so much for joining us this morning. You know, we're talking about something that's not new. You know, I've been in oncology for over 2 decades, and patient financial navigation, linking with nonprofit resources such as Cancer Legal Care and others has always been pertinent. But now with our new economic headwinds, the sheer cost of cancer care alone, this is a population health imperative. You know, for me, it's personal. I was a cancer administrator for years and got struck by cancer in 2008. Melanoma, don't talk about it a lot, but it left me $80,000 in debt. And I had amazing insurance and amazing care, and I was part of a large health system, and so many things were taking care of me. On top of it, my father, lung cancer, also left much more denominator on that one too. That was a lot to dig out of. Thank God I was wise and knew about, even then, copay assistance, foundational support, linking with other community, and that is our goal for all of our patients. Really, with our economic headwinds, just the sheer cost of cancer care, I truly believe that every patient needs patient financial navigation at this time. So today we're going to slow down, talk about navigation, that comprehensive approach in financial, talk about its benefits now, how to have an ROI for programs that don't have it, talk about some of its implementation considerations from stakeholder support to financial contributions, proactive patient identification, staff training and tools, and other strategic recommendations. I know that I'm sharing it from the background of Allina Health Cancer Institute. We're only 3 years young, and we now have 3 financial navigators, both virtual and in person, and plan to growing to all our 14 sites. For us, it is truly a population health strategy. You know, we are 3 years young, as we knew that we had to look at things different under population health as we move from volume to value. And this patient financial navigation is a part of whole person care. We know if we don't focus on this, we know that from financial toxicity, that it's also a barrier to outcomes. We know from our own psychosocial tools that the anxiety over the financial aspects is oftentimes greater than the diagnosis itself. These are a couple of latest quotes here. 27% of adults insured cancer patients report medication non-adherence. We definitely see this with our oral oncolytics and taking half a pill or not filling that up too, just for the sheer cost of it. A survey of breast cancer patients too found that 94% of this population wanted to discuss cost of treatment, but only 14% reporting having that conversation. So the why is relevant. All of us in this room know of a patient that had that financial burden, or that terrible word, financial toxicity, associated with the cost of cancer. 71% of patients have experienced financial hardship during their first year of diagnosis, and almost 100% of those had great insurance. In 2018, take it that is almost going on 6 years ago, U.S. patients paid $5.6 billion out of pocket. That number has doubled by 2023. So our goals at Allina Health Patient Financial Navigation Program is really simple. We want to link all patients up to be able to support them in patient copays, patient foundation, making through our social work with our social workers also, the wonderful navigation of our community partners. From Angel Foundation in the room to Cancer Legal Care too, we are blessed in Minnesota to have so many amazing nonprofits, more so than Wisconsin and any other region I've worked in. Our goal is simple: focus on copays, focus on foundations first, pharmaceutical second, making sure that access is not a barrier for our valued patients, and making sure we're efficiently enrolling and addressing insurance coverage too, and optimization. This kind of shows a breakdown of how we look at this as integral to our services. Again, we want to connect our patients to financial navigation. We want to educate them also in their financial responsibility, making sure it's clear. We can't control the cost of oncology, but we want to make sure we can minimize its burdens. Let's use all those devices that pharma has made available to us, from patient copay to foundation support, to maximize on behalf of our patients. We want to also improve patient collections. And this was a win-win. When we look at this organizationally, this is a win-win. Anytime we put this in place too, we've actually at Allina, we've lowered our cancer-related bad debt by 15%. That is real money, but at the same time, higher patient expectations and lowering the anxiety, this increased anxiety, especially with our current economic headwinds around cancer care. So when we looked at that comprehensive approach, and when we started this 3 years ago, we wanted to rethink our approach. We realize, again, patient financial navigation is not new. We're not the first ones in the Twin Cities to do this, but we want to double down on this. So we looked at rethinking our approach by making sure that we also utilized software. Let's maximize those foundations. We know the peak season for out-of-pocket costs restarting. We know that there is a spike in patients needing these resources, and we wanted to have a modernized and differentiated approach at the Allina Health Cancer Institute locations. So we developed an SBAR. Oftentimes what you do when you're looking at a new business plan and so forth, this just shows kind of our background, but why the need. If we're going to truly say we're whole person care, we're there to minimize the financial toxicity around it, we knew we needed to have in-person and virtual patient financial navigators available at our locations, both regionally, both suburban and urban, of course, at our rural sites also. We knew that it also is a multidisciplinary approach. It's not just starting with these brand new financial navigators, but it's working with our amazing social workers, the behind the scenes too with revenue cycle and making sure it's truly cohesive there. It's also pharmacy, laboratory, it's radiation oncology. It's not, I talk a lot about the oncolytics. That's a big part of the pie, but we are also looking at that whole cost of care within the system. In our task force chart, we created a task force with all these various teammates on it, and truly its charter was simple, to ensure that our ALINA standards are being followed, and our goal is access and reduction of that financial toxicity for our patients. So some of the core pieces on there is we wanted to make sure we identify patients early, that we're using it's beyond like our stress thermometer, that we're utilizing digital devices, our app to make sure that we address it really early. And financial navigation too is meant to catch it early, but to be all the way through the cancer continuum through survivorship. We also knew that we're starting, even though we're not new to patient financial navigation, we know that we had a big buildup to make sure our navigators had the resources, that education. So it's working with ACCC, working with Wisconsin and Michigan programs too that have mastered it for years, our outside partners, and we also looked at having software. And the software we did choose was called Viver. It's now called TaylorMed, but it's ingenious in its design that it actually is able to, once you put the patient in there, it actually knows what foundations are available and when, and automatically applies for those funds. When we look at our comprehensive, our continuum, cancer care continuum, we want to make sure that navigation intersects in all the areas. Like I mentioned, from early detection to diagnostic to treatment, all the way through survivorship. It's not, not one piece, but we know that financial burden or toxicity related is there throughout the entire journey. So how did we get started? Of course, I love that word pilot. We piloted at our beautiful Allina Health Cancer Institute location at Mercy Hospital. But then from there, we extended it to Buffalo and now to St. Paul and Minneapolis and so forth. We knew that it was going to be a shared management role with revenue cycle. They have to work hand in hand, so all those credits are applied to the patient's bill, and that we're adjusting their payments too. Our vision was simple again: proactive patient identification, noticeable reduction in that financial toxicity to assure access, and that nice ROI in the back, that we're minimizing that long-term patient bad debt also for oncology. We established a financial navigator role, and this just shows just some of the pieces that they work with. It is billing. It's looking at denied claims too, but really maximizing, again, copay assistance programs, the payments, making sure they're an extension of social work also, with local support and charity care, and having some of those secondary coverage options, assistance also. I mentioned we used software. There's a bunch out there. Some of them have consolidated, but at the end, a lot of efficiencies we know are gained through technology. So on this side here, it shows all the various things that we wanted our software to do, and it does. And we still have a ways to go, but also quantifies for us. To this date, $1.3 million. These savings add up really quick with patient copay, $1.3 million, and we just established the program just a little over a year ago, April 2022. Our journey milestones is really just as HCI, the Allina Health Cancer Institute, is only 3 years young. It was really just rolling these out to our metro and our suburban and some of our rural sites too over the course of these 3 years. And we're not done. We're halfway there with extending robust navigation experience in finances through all our locations. these are our milestones. We wanted to first connect. We wanted to really, we're kind of there to optimize, again, patient coverage, that external assistance. And really where we are right now is milestone 6, just making sure we expand it to all sites. I really feel strongly that I think all patients need a component of this in their journey. And we know that some of the silver linings with COVID is we can do this really well virtually. And that's one thing we've mastered during COVID is also our virtual design too. So it's both in person and virtual. We know our results. We know that it would compel just the sheer cost of oncolytics and the cost of cancer care to be able to link to immediate foundation and save copays. It's very easy to get into the millions really quick. Additional, as I hand it off to Lindy also, is hooking with our partners. Financial toxicity is hitting in all different ways, including legal care, access, or even access. They'll focus on paying their healthcare bills, but also it's electricity, it's gas, it's everything else, food, insecurity too, and so forth. So making sure that we are good stewards of that and accelerating that through our social work and early intervention, but working with all the community support here too, making sure it's housing, it's gas, it's getting patients rides over, and really securing other avenues for support. Resource collaboration, before I hand it over, it truly is collaborating with our partners out there. With David in the room from Angel Foundation to others, truly addressing financial literacy to having that standardized approach and just becoming better stewards of these resources for our patients. Before I hand it over to just some of our lessons learned. We know that we have a long ways to go. We're only really in our 3 years young, the Allina Health Cancer Institute, but only a year and a half into patient financial navigation. And so we want to keep building on that success, hiring more navigators, getting them the resources needed, making sure it's integrated into our care pathways, that finance is just really integrated into our conversations with patients, ensuring all those stakeholders too are part of that village of support. And I'll hand it over to Lindy, and we'll ask for more questions at the end. Or ask for your questions at the end.
Thank you, Mike. Hi, everybody. Can you hear me in the back there? Okay, great. I'm Lindy Yokanovich. I'm the founder and executive director of Cancer Legal Care, where our mission is to engage the law to resolve the complex challenges facing people and communities affected by cancer. And financial toxicity is one of the biggest challenges that our clients are facing. We've been doing this work since 2007 here in Minnesota, and when we started, nobody could figure out why the heck would anybody need to talk to a lawyer. My dad used to say, these people are already suffering, why are you going to make them talk to a lawyer on top of their cancer? But the world has really caught up with where we were when we started because of all the things Mike has just talked about and more that I'll share with you here today. And these have been going on for decades. 41 years ago, my mom was diagnosed with colon cancer long before the protections of the Affordable Care Act, and we lost our health insurance in the middle of her treatment. And she was able to get insurance in Holland. That was really great, but this is back in the days when you had to lick a stamp and put it in the mail and wait for it to get over there. And it required that she pay all of her bills in full before they'd reimburse her. And after about 6 months of this, her doctor heard about it and said, well, for heaven's sake, let's just mark her bills paid and we'll get paid when she gets paid. And if it hadn't been for that intervention of that doctor, my parents would have been in the exact straits from a lot of the statistics that I'm going to read here too. But there has to be more than kindness of one individual person. There has to be systemic change. There has to be policy changes to really address this problem because it is huge. And for, when my parents were going through it, it was shameful. You didn't want to talk about that. You didn't want to tell anybody. You didn't, your finances were not what they should be, that you didn't have insurance. I mean, it was terrible. And I think a lot of that shame still persists now. But if you'll indulge me with a few statistics here, I just want to give you a grasp of how huge and pervasive this issue is. So 42% of new cancer patients will deplete their life savings within 2 years of diagnosis. And the average expended loss there was nearly $100,000. And this was a huge study that looked at millions and millions of cancer patients across the country over more than a decade. Cancer patients on average are about 2.5 times more likely to declare bankruptcy than those without cancer. 33% of women diagnosed with breast cancer who are working at the time they're diagnosed are no longer working 4 years later. 62% of personal bankruptcies are filed in part because of a large, significant piece of medical debt. And when you look at those filers, 78% of them had insurance. So this is not a question of people not having insurance or not having good insurance, like Mike was saying about himself and his mom and dad. After a cancer diagnosis, the probability of a patient being employed drops by almost 10%. 14% of Minnesotans are insured by high-deductible insurance plans, which is nearly twice the national average. And the impact that this reality has on people's survivorship is real. Cancer survivors who file for bankruptcy are 80% more likely to die than cancer patients who do not. I'll say that again. Cancer patients who file for bankruptcy are 80% more likely to die than their fellow cancer patients who do not. The stress that this takes on survivorship is incredible. 70% of oncology providers are concerned with their cancer patients refusing treatment because of financial worries, and 49% have had a cancer patient refuse treatment because of financial concerns. From 2003 to 2006, that's almost 20 years ago, more than 2 million cancer survivors in the United States did not get one or more needed medical services because of their financial concerns. So these are widespread systemic public health problems that really need to be seen in the light of day and addressed head on. Since we started providing legal services back in 2007, we've served over 13,000 Minnesotans with our programs and provided legal care services valued at more than $18 million. We are the only organization doing our model of care in Minnesota, certainly, and really all over the country. We use both staff and volunteer attorneys, and we are here for anybody affected by any cancer living anywhere in Minnesota. They do not have to be in active treatment. They do not have to live in the Twin Cities. They don't have to have just a certain type of cancer. We're here for everybody, caregivers, patients, people well into their survivorship, because these issues have a long, long lifespan. We talk a lot about the social determinants of health, and that's, when we were starting, nobody talked about that. And now there's lots of talk about it and lots of hand-wringing and lots of admiring the problem, but there's very little actual work being done to address those social determinants of health. And when you look at them, they are intricately linked to legal issues: housing, discrimination, lack of coverage, employment. They're all things that lawyers deal with all the time. So having a multidisciplinary approach, as Mike was talking about, is key to really addressing these problems head on, because for so long they've just been dropped at the feet of the healthcare providers. And we've had countless doctors, nurses say to us, I really do care about my patients, but what do I say when they tell me they're going to lose their house? I don't know what to say, so I don't want to ask because I don't know what to do. And that is a superhuman, understandable response. And so what we're trying to do at Cancer Legal Care is be that place where people can come for help physicians, providers, nurses, social workers, financial navigators can refer folks to us, and we can help to try and get them back on a path to answer their questions. So, as Mike was saying, he had good insurance, his dad had good insurance. All of our clients have insurance. I mean, Minnesota is, high rates of insurance. So why are people facing all this financial stress when they have good insurance? And I'll tell you a few reasons, what we see at Cancer Legal Care. So first, unpaid leave. If you need to take time off from work, the Family Medical Leave Act is job protection leave from work, but it is not paid leave. If you have other leave, paid leave, vacation, PTO, you can get paid for part of the time that you're maybe out on FMLA, but if you don't have that, if you've just recently changed jobs and don't have any FMLA protections, if you work for a smaller employer, there's no requirement to do that. Now in Minnesota, we've just passed paid leave, which will be implemented over the course of the next few years. But that is a huge reason why people fall into this pit, because they all of a sudden can't work and they don't have any income. A second reason is lack of practical and income replacement supports. So childcare, other debts before cancer, still those needs are there. And there's really a lack of access to disability benefits in the short term. Some people might have private disability benefits, short and long term, through an employer or that they secure on their own. But people who do not may think, gosh, I can just go on Social Security disability. I've heard about that. It is very complex. The threshold for meeting that definition of disability is very, very, very high. And then the third big reason that we see is that good insurance that everybody has, that they're relying on, oftentimes is what's really challenging them. They might have a high deductible. So folks who are diagnosed at the end of the year and have to meet a $7,500 deductible in December, and then once the calendar turns to January, that can wipe out most families. Shrinking networks, out-of-network bills. We have a client who's joined our board, and he came to us 2 weeks after his wife had died. He got an $135,000 out-of-network bill for his wife's last cancer care. And when he called us, he said, "I feel like my head's going to explode." And that was because of one of these out-of-network doctors, in-network hospital, and there's been legislation since then to try and address that and resolve that in Minnesota, but that's a huge problem. Prior authorization holdups and delays. Erin Hartung, our Director of Legal Services, is here. Wave, Erin. And she runs our insurance appeals work, and she can tell you stories about prior authorization denials, delays that would make your hair stand on end. And some people are just opting, I have to get this treatment, I'm just going to do it anyway, or I can't afford to, I'm not going to do it, and they delay and delay and delay their treatment, and their cancer gets worse. And then I'll just call them administrative kerfuffles instead of the word I really want to use. But there's all kinds of administrative entanglements that can happen between well-meaning providers and the insurance company. And who gets lost in there and who really pays the price is the patient. So at Cancer Legal Care, we are here to help with issues that come up about employment, issues that come up about housing, evictions, foreclosures, and other debt situations with dealing with debt collectors. Insurance, like I was saying, is a huge issue that we help out in. Legal planning, estate planning for folks who don't have the financial ability to hire an attorney to do some estate planning for them. And then public benefits, helping people make timely and well-pled applications for Social Security disability insurance or SSI, the Supplemental Security Income. We have a program that we've just launched this year that allows, with a contract with the state DHS, they pay for our costs in getting people onto benefits so that when somebody does get onto Social Security disability, if they had hired a lawyer, the lawyer would have taken an $8,000 statutory payment off of the top of their award. We do not take anything, so that our clients are on the best financial footing they can be with starting out their new life as a survivor. So that's really all I had prepared. I can answer questions forever, happily. So thank you all for your interest in this topic. The only way it's going to change is when more and more people are talking about it and versant about the tremendous impact that it has on people's lives and survivorship.
Very much. Appreciate your time, the information. We have some time left for question and answers. I'm sure there's a lot in the room. So I'll come and bring around a mic. Raise your hand. I saw one over here. We'll get started.
Hi. How do you guys have deal with, you've been addressing the financial literacy, but how have you been addressing the technology literacy? Because we've seen a lot of clients that there is that gap on, we can provide the resources, but if they don't know how to navigate that online, the IT literacy. For both, because I saw the timeline, but how do we, they're dealing with the stress of the news. On top of that, they have to learn how to navigate the.
So at Cancer Legal Care, we really.
Lindy? Yeah, there's a mic on the table. Test.
At Cancer Legal Care, we try to make it as low-tech as possible. Folks call us on the telephone, a lawyer answers the phone. That's it. We have done things before where we partnered with cancer clinics where our lawyers are in the clinic and are right there, so a social worker can walk them right down the hall and say, let's talk to Aaron about that insurance issue you were worried about. Some of our clients are very tech savvy, others aren't. There's a lot of connectivity issues for our clients who are in greater Minnesota. So we try and meet each client where they are. We've had clients with oral head and neck cancer who've lost the ability to speak and they can only communicate via email. We are set up to do that too. So we're trying to break down as many barriers as there can be, because it really is inherently terrifying for most people to contact a lawyer, or they're completely out of their element. They just don't, they don't believe it's not going to cost them anything to talk to us. So we're trying to make it as approachable and authentic and human as possible.
The same thing, it's our making sure that they're part, we have a village of providers, over almost 30 amazing oncology nurse navigators, to, I mentioned social workers, to all the aspects, and making sure that that intersection, if they know that they're dealing with the financial stress or burden, we want to be there. But we also, our tools to make sure they're culturally appropriate. There's, that we're, embracing, diversity in that piece to make it as simple as possible to access the many resources out there, removing the obstacles, because they're not easy. Oftentimes, here's your copay card and how you I have this credit card to take off on our, no, it's not as simple as that. So our goal is make it easy, utilizing software even to make it even easier for our patients.
There's a question right here.
I just wanted to touch on, I'm a stage 4 cancer survivor. I'm 9 months out from treatment, and I'm on my 3rd appeal for disability. So it is truly a problem. We have 3 kids. I have great health insurance. I worked for a clinic. It was bad timing. Our oldest was going into college, and there's just not the help that you need for that.
Right. I'm so sorry to hear you're dealing with all that, if it's any cold comfort, you are not alone. And the thing is that nobody really should understand how Social Security disability benefits work just when you're going about your life, but here comes this cancer diagnosis, and all of a sudden you've got to figure out your health insurance, which is a whole other universe. You've got to figure out, am I eligible for Social Security disability? You know, how does this work? And, you know, one thing that most people do not understand is that those Social Security benefits, the disability benefits, are basically the same ones you'd get once you reached your retirement age, but if you're younger than that and become disabled, you can access those benefits early. That's sort of a generalization of what those benefits are. But in order to meet Social Security's definition of disability, you have to not work or be able to earn more than a certain amount of money, a little over $1,000 a month, and you have to have a condition that is expected to last 12 months or result in death. So that means that it's not for, you know, a bad broken leg from a ski accident. It is for really, really challenging health situations. And for cancer folks, broadly speaking, without any other issues, other health issues, that's really a stage 4 diagnosis. Even so, as you've shared, that if you apply too early in that 1 year timing period, they're probably going to deny you because they think, you know what, you're going to get better, you're going to feel better in a year, within a year, so come back again. And people are just left completely unaware, and we're happy to talk to you at any time if you want to reach out. Thank you for coming to my TED Talk all about how much I hate Social Security disability benefits.
This is more directed for the first speaker. You mentioned a couple of times that you have hardwired into the process how to screen or figure out which patients are in need of financial support. Do you have anything else you could share more in depth on what those hardwire processes are, or like, is there a flag in the chart, or what are you using as far as a screening tool?
Yeah. You know, part of Allina Health's population health strategy is when you go to any visit right now, they're actually asking you, are there barriers to pay? That's one, and that's embedded in the EMR red flag. Let's address that early. On top of it, in oncology, we utilize the NCCN stress thermometer, which for us is electronically embedded. So that in there too, that part of our social psycho barriers too. Let's add financial piece in there too, and then it truly is just making sure that navigation is at the very beginning. Let's talk about not only the care plan there and being able to navigate through that, but also address what are the bills going to be looking like and how to address those early.
So, hi, Lindy. Is there an anti-discrimination clause in place for patients receiving care? Because a lot of patients are able to work through their illness and treatment, but this is just anecdotal through a friend who shared that she felt like pregnant women are not asked to stay home, but she was under a narrow focus, constant scrutiny, and pressure to go on leave while she was undergoing treatment for cancer. So just wanted to put it out there like a discriminatory law or rule, because there are a lot of sick people who can pull through, especially depending on where they are in the cancer continuum.
Right. So there in the employment realm, there are employment protections for folks under the federal American with Disabilities Act and the Family Medical Leave Act. And in Minnesota, we have the Minnesota Human Rights Act, which adds some more protections against discrimination for the very things you're speaking about. And what we really see at Cancer Legal Care is either people who have incredible employers and are paying them even though they're not working, I mean, for a year and a half, they're still on the payroll, they're just going above and beyond. And then horror stories. So there is, you cannot discriminate against in the workplace somebody who has a disabling condition like cancer. Oftentimes people are extremely sensitive about that and how they're being perceived, and it may not be an intentional, it may be a miscommunication, or it may be very intentional. So there are protections there, but it is challenging to prove. And so if somebody is experiencing that, they should be keeping very good records and documentation about what they're experiencing. Yes. Yep. So this is the fun part about law, is that the term disability means completely different things under the Social Security laws and under the American with Disabilities Act. Under Social Security, the disability is stratospherically high to meet. Under the Americans with Disability Act, it is purposefully, it's even been amended to make the threshold for finding disability very, very low, so that more and more people are protected in the workplace from discrimination. So that's why, I mean, Google is, my friend's lawyer says, don't confuse your Google search with my legal education, but I would say that if, contact us, because it is very person-specific, situation-specific, and when people sort of just do a broad stroke of what they think it might be, they really lose out.
So I come from a legal aid background, and I have to ask the question, what are you using as like your financial qualifications? Are you using federal poverty guidelines? And I ask that because middle class is the worst place to be. And so, if you get diagnosed with cancer, you don't meet the federal poverty guidelines, do you still get that assistance from your legal aid? And then the other question I have on the other end is, how are the financial navigators paid? Are they billed to the patient's bills? I mean, are we paying for them, or are they just a service that the hospital covers to ensure that the patient has that service?
Yeah, so all of our legal aid here in Minnesota, like everywhere else in the country, is tied to a very, very strict 200% or 125%, depending where you are, multiplier of the federal poverty guidelines. When we designed cancer legal care, we weren't trying to design a better mousetrap, we were trying to design a completely different beast. So we do not have, we collect income information from our clients, but everyone, regardless of what their income or asset level is able to get assistance for information and advice, and all of the private health insurance appeals, because nobody could afford the amount. If you could find a lawyer that was working on the patient side, and the incredible, I mean, Erin and her team one time put in 60 hours in 1 week for an appeal. There's just no way that anybody can afford that, and we're able to do that quickly and with the funding from our donors who really want us to. The only income cutoffs we have is for our Social Security work. DHS has some requirements, but we're working with them to educate them about financial toxicity. So DHS has expanded their definition, and so we're able to help a much wider group of people. And then our estate planning work is at about a 300% level, because you're right, middle class is the worst place to be.
At Alina, all navigation is not billed to the patient. We consider that to be a part of patient care. It's unfunded. It depends, as you know, it depends on industry, or pharma is becoming much more flexible with those income pieces for eligibility. So so we have to go by those guidelines, and of course the foundations. But our goal is that it's accessible for all.
So I have a question, and then we'll see if we have time for one more. But Mike, I'd be remiss in this session if we didn't address the headlines recently with Alina and patient billing, patient care. how can cancer patients be assured that they'll continue to receive their treatments?
Yeah, in unfortunate article that we were not able to participate in the interview and so forth. I'm passionate in oncology. That there is no patient turned away. We have offered, I would have loved to give this as a rebuttal to New York Times, $1.3 million in savings to our patients. That's truly reducing their bills, their out-of-pocket costs, just in our first 18 months of operations. So again, it's huge. We have a long ways to go, and this is just one of over 50 other devices in the organization to reduce the financial burden for our patients.
Think we might have time for one more, and then we'll wrap it up.
Thank you. So I was just reflecting on some other things I heard this morning. So from Dr. Cunningham, that incidence is increasing, mortality is decreasing, which means more people are living longer with cancer. We're having second and third and fourth line treatments, keeping people alive longer, which is a good thing until you start thinking about the financial burden. I was also struck by a number that you mentioned, Mike, that the cost out of pocket has doubled. Am I correct in thinking it's about $10 billion now? And if it continues to double, as great as your navigation is, I'm envisioning a trickle of resources into a bucket and a gushing of resources out the other side. Is there a concern that at some point, no matter how good your navigation is, there just won't be the resources to support patients in need?
It's a huge, that out-of-pocket expense is tremendous, and based on certain cancer diagnosis. Other components of financial navigation includes clinical research. That's also a device too, of being able to make sure we have access to our novel treatments. Also, the huge cost associated with precision medicine. All those molecular and genetic costs have huge out-of-pocket costs. So we're interested in having those in translational studies for our patients, but also we want copay assistance and foundational support also for that. So we are concerned over, we're excited over all the clinical innovations in cancer care, but their associated costs have been a runaway horse for many, many years.
They haven't come to cut us off. Are you open to more questions if there's still audience questions? Is there anyone else?
I have a question. Lindy, I can't imagine the volume of calls that your office gets. If you have a friend or a family that you anticipate might have some financial toxicity, which would probably be the majority of patients, would you recommend that they reach out ahead of time to be proactive or wait until there is an issue?
1,000% reach out ahead of time. Lots of times we do what we call a legal care checkup with folks who are just newly diagnosed because they don't know what they don't know. And we're really good at listening for cues for how much people can handle, because it is overwhelming. But we really try to establish that relationship and a place where folks can come back and speak to Erin specifically, not just calling into a care center. And so once that relationship has been created, then it really does allow the pathways to address issues as they come up in real time. Thanks, Marilee.
Hi, everybody. I'm with Dave Becker with Angel Foundation, and I would be remiss if I didn't just mention we started a pilot. It's called Financial Cancer Care, and this was a pilot we did for 2 years researching financial toxicity. And I love hearing these conversations because this is such an important topic. So many people are impacted. But what we found was there, like Lindy was saying, there was oodles of information on research and data on the problem and very little in the way of the solution. So I'll give the 30,000-foot view. We link a patient with a social worker. We identify immediate needs at Angel Foundation, and then we have trained, certified financial planners, pro bono financial planners, much like Lindy has attorneys, because it's such an incredible need. We do not have a financial minimum criteria for this program based on what we heard today. you almost have to fall down before you get help. So we're trying to go upstream, help people before they fall down. So very similar service.
Making me get my steps in. It's okay.
I have a question for both of you. I work on more of the advocacy policy change side of things. For both of your issues, both like in the cancer legal care and from this financial patient navigation standpoint, like what would be your like ideal policy change that can help address some of the issues that you see? Like if you could like pass some major bill, right? Like how do you think you would try to address the needs that you see the most?
Our number one policy initiative at Cancer Legal Care is to work to stop the 5-month wait for Social Security disability benefits and the 29-month wait for Medicare coverage. There's a couple pieces of legislation pending. One is called the Stop the Wait Act, and that's for all impairments. And then the metastatic breast cancer community has one targeted for breast cancer. But that, if people could immediately, when they're eligible for Social Security disability, begin cash benefits instead of having to wait 5 months, which is the requirement now, which there is absolutely no rhyme, reason, or grounding in, that would be huge. And then to allow them to start on Medicare rather than waiting 29 months to be eligible from the date of their total diagnosis.
And I would too, policy change to make sure that we have equity in terms of insurance coverage. There are still so many junk policies. I remember one big name years ago that truly excluded cancer coverage and just held claims forever. And it's just part of the mess. Yeah.
Anyone else? Do either of you have anything you want to add or conclude with? Otherwise, I think we can wrap things up.
Thank you.
Thanks so much.